Oh iya, ini bukan Lenovo juga. Jangan. Oh.
Good afternoon, ladies and gentlemen. Yang berbahagia, Prof. Dato Dr. Adeeba Kamarulzaman, Chair of Rose Foundation, Professor of Medicine and Infectious Diseases at Universiti Malaya, member of the WHO Science Council, Mr. Mark Odell, Liam CEO, our distinguished speakers from Rose Foundation, namely Dr. Zakiyah Matzahi, from Public Health Physician, Family Health Development Division, Ministry of Health Malaysia. She's also the chair of the Malaysian Cervical Cancer Elimination Task Force Committee. Professor Marion Saville, Executive Director and Public Officer, Australian Centre for the Prevention of Cervical Cancer, ACPCC, from Melbourne, Australia. She's also the trustee of Rose Foundation. Professor Dr. Wu Yin Ling, from the OB and Gynae at Universiti Malaya. She's also the consultant gynae oncologist in University of Malaya Medical Center. Also a trustee and medical technical advisor of Rose Foundation. Professor Karen, the Director of Cancer Research Division at Cancer Council NSW Australia, current conjoint professor at UNSW Sydney. Our invited guests from Negara Malaysia, representatives from Rose Foundation, stakeholders from the financial services industry, our colleagues from Life, General and Takaful industry, members of Liam, ladies and gentlemen, Assalamualaikum and a very good afternoon to all of you. Welcome to the inaugural webinar by Liam and Rose Foundation on the topic Towards Cervical Cancer Elimination in Malaysia. Before we begin, allow me to introduce myself. I am Shida and I'll be your MC for today. We are indeed privileged to gather here today to hear more from the experts on the topic of this webinar. Please stay tuned throughout this webinar to learn more on the developments in cervical screening and Hpv tests and to keep ourselves updated so that we can make informed decisions. Ladies and gentlemen, I think we have about 100 of participants who have joined us today. Without further ado, let's hear more from Mr. Mark Odell, Chief Executive Officer of Life Insurance Association of Malaysia, with his welcome remarks. Over to you, Mr. Mark.
Mark, you're muted.
See, even I unmuted before, then it muted again. So
yes,
sorry.
I was about to unmute you. Okay, now we can hear you clearly. All right, you can start all over again, Mr. Mark. Yeah.
Thank you. Let me just start. I just by welcoming again our guest speakers from the Rose Foundation and related entities. So, Professor Dato Dr. Adeeba, welcome. Chair of the Foundation, Dr. Zakiyah Binti Muhammad Said. Professor Marion Saville, Professor Dr. Wu Yin Ling, Professor Carol Canfell, welcome all. And I think the lineup of speakers today speaks to the importance of the topic. I'd also like to welcome our invited guests from Bank Negara, Malaysia, who actually were responsible for marrying or putting together the Rose Foundation and the Life Insurance Association of Malaysia. So again, a very good afternoon to you. This is the first joint collaboration that we bring to our members. I'd like to express my appreciation for your interest in attending this webinar and for the Rose Foundation for co-organizing it. We all understand the importance of education. Hence, today's webinar is to educate, generate awareness, and provide further understanding on the developments in cervical screening and HPV tests as the preferred and primary form of screening. I think one thing that really struck me anyway in learning and speaking to our colleagues on the session today is first how preventable cervical cancer is, and secondly how detectable it can be, and the advances in the screening technology. We'll hear more about, I think, what we call the PCR of HPV versus Pap smears and its implications when it comes to underwriting and claims, and of course, most importantly, the well-being of those who may be affected by this virus. You think about COVID-19, the pandemic hit many countries all over the world. It's become a wake-up call and an eye-opener for all of us. The virus taught us to be more sensitive, more cautious, and more responsible in ensuring ourselves and our loved ones are safe, protected, and healthy. Our collaboration with the Rose Foundation is timely and beneficial as we continue to proactively play our role in creating awareness and reaching out to the community around us. It's especially timeliness because this coincides with tomorrow, as you will know, right, is the International Women's Day 2022, which commemorates the cultural, political, and social economic achievement of women. Indeed, this webinar is all about caring for women, although, as those of you who are well informed know that this virus affects men as well, maybe in a different way. But, you know, we think of cervical cancer, but those that carry the virus oftentimes are men. So it's not just about women, but it certainly affects women in a very serious way. I'm made to understand that cervical cancer is one of the most preventable and treatable forms of cancer. It is prevented with HPV vaccination, detected early and managed effectively. Hence, through this webinar, I hope you'll learn more on the topic and keep yourselves updated and well informed to reduce the incidence of cervical cancer. According to the WHO, cervical cancer is the fourth most common cancer among women globally, with an estimated 600,000 new cases and 340,000 deaths in 2020. About 90% of new cases and deaths worldwide occurred in 2020 occurred in low and middle income countries. As such, awareness and education are important because cervical cancer can be cured if diagnosed at an early stage and treated promptly. Our line of distinguished speakers will tell us more on this topic. Please stay with us throughout the webinar as the speakers will share their knowledge and expertise, their perspectives on Pap smear versus HPV testing, its cost effectiveness, and many more. Our purpose in the areas that Liam is supporting the Rose Foundation and this messaging is twofold, really. One is we would like to start with awareness and spreading the word and education, actually with all of you and all of your company, your staff, your colleagues, policyholders, etc., about the awareness of HPV testing as well as vaccinations. And then secondly, another important and relevant aspect of today's session is to increase awareness of the use of HPV testing and the prevalence of the virus in the population and the consequences of a positive PCR test on claims and underwriting. And I'm told that many insurers treat HPV positive in the same light as all other sexually transmitted diseases that often leads to claims and underwriting complications. When in fact, I'm hopeful that after you hear from the speakers today, you'll look at this in a different light, and then you'll be able to see it for what it is. And that is really something that is prevalent across all of the population, and it should really be looked at in a different light when it comes to claims and underwriting. So with that, I'll hand it back to Sheeta, and I look forward to hearing from our speakers today. Thank you.
Thank you, Mr. Mark Odell. Before we proceed to the next agenda, we would like to invite Yang Berbahagia Prof. Dato Dr. Adeeba Kamarulzaman, Chair of Rose Foundation, to deliver her speech. Ladies and gentlemen, please welcome Yang Berbahagia Prof. Dato Dr. Adeeba Kamarulzaman. Over to you, Prof.
Thank you very much. It's really cats and dogs where I am here. I hope you can hear me well.
Yes, I can. In fact, my side as well.
Yeah. Okay, that's a lot of thunder. First of all, let me thank Mr. Mark Odell and Liam for organizing this webinar. I'm really encouraged and heartened by the number of attendees at this webinar, and I just want to say a few words to take up where Mark has left in his opening remarks. You know, we're currently living through probably the worst of times. We have a war on the other side of the world going on. We have climate change that's causing this rain every day in March, heavy rain and floods. And of course, we're living through a most horrific pandemic that I dare say none of you have not been touched by it one way or another. Thankfully, for the advances in science, we have a vaccine for the COVID-19 pandemic, and we have tests that I think many of us have now taken for granted. You know, we stick swab in to make sure that we're not positive, or we spit into a jar to make sure that we're not positive before we go out these days. Now, why I'm saying all this is because when it comes to cervical cancer, that same technology, the vaccine and the tests, have actually been around for much longer, obviously, than COVID-19. And together with all of you, we can actually look at eliminating a cancer, the first time that, you know, humankind will be able to eliminate cancer. And here in Malaysia, I think we certainly have the opportunity to do that. I mean, you have seen how when Malaysia and Malaysian government and Malaysians put our minds to it, I'm referring to the vaccine, we can do it with the COVID-19 vaccine. We stand as one of the countries with the highest vaccine rates in the world, and because of that, I think we're somewhat able to withstand the onslaught of the Omicron. It's despite having tens of thousands of cases, it's nothing like the Delta wave. So if we put our minds and our effort together with the human papilloma virus this time, inshallah, we'll be able to also, you know, show the world that we can eliminate cervical cancer. It's the nature of medical science that it takes years for us to implement, you know, something that has been shown in science. It is said that it takes about 17 years from evidence to implementation. So let's not make the same mistake with cervical cancer, because we definitely have the tools. We have had the vaccine for a number of years, and the government is committed to expanding it. You'll hear more from Dr. Zakiah from the Ministry of Health and the plans. And we have, you know, this self-test that empowers women, that will be the other tool that is needed to eliminate cervical cancer. So because there remains a few challenges, not least of which is the provisions with the insurance, etc. That was what prompted us to approach Liam to see how we can overcome this challenge. And the result of this is this webinar. So I do hope that all of you will, after these presentations this afternoon, from colleagues from Dr. Zakiah from Ministry of Health and colleagues from Australia, the experience, and of course our very own Dr. Wu, that you will not just view cervical cancer as something within your portfolio that you need to tackle, but really join us in becoming ambassadors and really work towards eliminating cervical cancer in Malaysia, because it is possible, and it takes only a little bit of effort and of course investment, but also as the tagline for Rose, removing the obstacles that's going to make this possible. So once again, thank you very much for partnering us in this movement to eliminate cervical cancer in Malaysia and globally.
Thank you, Yang Berbahagia Prof. Dr. Adeeba, for the speech. And now, before we move on to the presentation, I would like to invite all of you to switch on your camera. We will now have a group photo session. Not your microphone, but it's just your camera. Maybe our distinguished speakers, can I see your faces? Okay, hold on. I'll just need to do a gallery. Let me see. Gallery mode. Okay. All right. With my count, I will count 1, 2, 3, and then I will take a few shots. Yeah. Well then, let us allow few more guests to switch on their camera. Okay, I can see a lot of beautiful faces, and of course, Mr. Mark, so handsome over there. Okay, with my count, 1, 2, 3. Let me do another one. Okay, 1, 2, 3. Right, thank you everyone. You may switch off your camera and then switch off your mic. Yeah. Now I would like to invite our first speaker of the day, Dr. Zakiyah Matzahi. She will be speaking about this topic towards cervical cancer elimination from the Ministry of Health Malaysia perspective. Over to you, Dr. Zakiyah. Dr. Zakiyah, you need to unmute yourself.
Okay.
All right, I can hear you clearly.
So you all can
you
see
may
my slides, right?
you need to change to presenter mode.
Yeah. Okay. Can everybody see my slides?
Yes, hold on. It's still showing.
I have put that under the
Presenter mode, yeah?
presentation. Yeah.
Maybe you press one more time.
Okay. Is that okay?
You need to press the presenter mode, that is Zakiyah.
Yes, yes. I have already pressed the presenter mode, the slideshow, right?
Yes.
Okay.
The small
So
icon that's showing the presenter mode.
Oh yeah. So is this okay with you all?
I can see the slide, but it's not showing in presenter mode.
Okay. So you all can see my slides now?
Yes.
But it's still not in the presentation mode, right?
Yes, exactly.
So how to do this? Okay, let me check this. Okay.
You can try to press.
I'll just stop sharing first.
Or stop sharing and then you try to share it again.
Right. Okay. So is this okay? Is this okay?
is still not in the presenter mode, but I believe we can see the slides. Can you go to the next slide?
Okay, moving.
Not yet.
Not. Okay. Okay, this is number 1. This is going to be number 2.
The
Okay.
introduction slide. I think
Okay.
you may begin, Dr. Zakiah.
Okay. Okay.
Right.
So, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and good afternoon, every one of you. So, on behalf of the Ministry of Health, I would like to express our sincere appreciation to the organizing committee for the invitation to this webinar session. And I think this is a very good initiative for the collaboration and engagement as many sectors as we can for the betterment of the women's health, especially to improve the access of the cervical cancer prevention and management program in our country. And I think that it is good to see many experts in this session, which will highlight the importance of the topic from the different views of their expertise. So this is my second slide. Can you all see my second slide?
Still not moving. It will take some time. Hold on.
Okay.
Yes, we can see your second slide.
Okay. So we know that cervical cancer is a preventable disease as it results by Hpv infection. And there are more than 100 types of human papillomavirus, but apparently there are more than 12 types that will cause cancer. And if the persistent infection happens, it will lead to precancerous lesion, which might end up with cancer if it is not detected early. Therefore, in May 2018, the Director General of the World Health Organization called for action towards achieving the global elimination of cervical cancer. And in Malaysia, cervical cancer is the third most common cancer. It starts to rise at the age of 35 and peak between the age of 50 to 74. However, 41% of women came at the late stage. So this is my third slide. Everybody can see my third slide?
Not yet.
Okay.
Yes, we are able to see. Can.
Okay. Well, I think for the vision of a world without cervical cancer, Malaysia is really committed in achieving cervical cancer elimination through ambitious goal for 2030. In Malaysia, women have been screened using a conventional Pap Smear since 1969, and it was the only primary screening tool available until 2019, and it ran as opportunistic basis. Well, the coverage of this opportunistic screening via the conventional cytology over the period of 5 years was dismal with an average of 25%, and this poor coverage was contributed to many factors. Noticing the gap of a single approach, Malaysia doubles out its strategy by introducing HPV immunization to hasten the reduction of cervical cancer. And with the success of a national human papillomavirus vaccination program, Ministry of Health recognized the need to review our national cervical screening program. While HPV vaccination will not remove the necessity for cervical screening, there is a need to transform to a more effective screening modality that is aligned with the current international evidence. Therefore, in 2019, we have endorsed our new screening policy, a shift from cytology to HPV testing via self-sampling. But due to the high cost, we have to implement it by phases and targeted with specific criteria of testing to ensure the maximum benefit to the women needed. So this recent endorsement of the policy has followed by a few other supporting elements, such as the development of the training modules for the healthcare providers, the establishment of the National Steering Committee and Technical Working Group Committee, and the recent one is the development of the action plan towards the elimination of cervical cancer in Malaysia 2021-2030. Well, with this recent endorsement of the policy the Ministry of Health has developed this action plan towards the elimination of cervical cancer, which encompass elimination goals and targets for scaling up of HPV vaccination, intensifying cervical cancer screening, as well as pre-cancer and cancer treatment. This plan identifies 5 priority areas of concern in attaining the set targets, strengthening the governance and policy, improving access and community participation, enhancing timely and high-quality service provision, augmenting intersectoral collaboration, as well as monitoring, evaluation, and research. Diverse stakeholders are brought together to nurture a strong collective supremacy in safeguarding the health of Malaysian women, especially in preventing precancerous lesion and cervical cancers through an integrated approach. So, eliminating cervical cancer as a public health problem is part of furthering this commitment and many others related to encountering inequities and advocating the rights of women and adolescent girls to high-quality, people-centered, equitable health services. And the success of the Infectious to eliminate cervical cancer depends on political volition, economies-led action investments, as well as unceasing and versatile collaboration. With that, I'll thank you.
Thank you, Dr. Zakiah, for an insightful perspective. In fact, ladies and gentlemen, for your information, we have allocated a slot for question and answer session later. Should you have any question, you may raise it during that session. As an alternative channel, you may also type in your question onto the chat box and we will attend to the questions later. So now, ladies and gentlemen, I would like to invite our second speaker of the day, Professor Marion Saville, who will speak on the shift from Pap Smear to HPV test on a global perspective. Over to you, Prof.
Thank you very much for the opportunity to speak to you today. I will just share my slides. It's just coming up now.
Yes, we are able to see your slide. Thank you.
Thank you. I will go quite quickly. You can see my disclosures there, but I think the important thing to know about me is that I'm a cytopathologist, so I made my career in reading Pap smears. And as you'll see, I'm very convinced that this is no longer the way to prevent cervical cancer. So in this presentation, I'm just going to touch on the natural history of HPV and cervical cancer. I'm going to talk to you about how cytology has reached its limits in our program, the impact of vaccination, on precancer incidence and on cancer, the effectiveness of screening, and the importance of cancer screening registers. So one thing that's very important to understand over here is that in a normal uninfected cervix, if you do a Pap smear, you'll see lots and lots of cells. That's our haystack. We're looking for the needle, which is the precancerous lesion. We don't see any. And if you did a biopsy at this time, it would look very normal. Once we have an infection, where HPV can be detected, actually on the Pap smear, you start seeing the effect of the virus on the cells. And that's what we're one of the things we're looking for in Pap smears, And we can also see a change in the biopsy. However, Pap smears are quite insensitive, and you can have completely normal findings even in the presence of infection. Now, this is not truly a precancerous abnormality. This is an infection that is very likely to resolve or clear without any clinical symptoms or knowledge that you've had HPV. And indeed, most of us will have an HPV infection sometime in our life and resolve it without ever knowing about it, most commonly in young adulthood. However, for some people, they don't clear the infection, and we don't know why that is and why certain people don't. But what happens is then an interaction between the genes of the virus and the genes of the cells of the cervix, resulting in what we call a high-grade lesion, which is the precancerous abnormality. And we can expect, if untreated, about a third of people with those lesions will develop invasive cancer over 30 years. So that is what's giving us time to find these lesions and treat them before they become cancer. And that's why the natural history of HPV has so many opportunities for prevention. This is the target lesion. This is the abnormality that we're looking for in our screening program, whether we do it with cytology or we use HPV tests. As I've said, invasive cancer can be detected in cytology samples and on biopsies, and also by HPV testing. But an important thing to understand here is that from high-grade cancer, we can get regression back. And also with HPV, we can enter this phase called latency. And this is when we can't detect HPV in any of our tests, but in fact, it's still there present in the cervix, and it may be reactivated later in life. And this is really important to understand, that HPV that's detected in a screening test doesn't mean that the person acquired the infection in the last couple of weeks. Indeed, in mid-adult women, it's far more likely that they've had it for quite some time. And the longer you've had that HPV, the more likely it is to be associated with this precancerous abnormality. So it's a little bit different from some of the other infections that we're more familiar with that have a shorter time course. So what has been happening in Australia is that back in 1991, we switched to our organised screening program. We got some cancer screening or cervical screening registers. We regulated the quality of Pap smear laboratories, and we did active recruitment. And you can see over the 10 years after doing that, that we had these really nice falls in cervical cancer incidence. But since the early 2000s, we haven't been able to get the rate any lower. So the rate seems to have plateaued, and we seem to have done the best we can do with a program based on cytology as the primary screening test. What all this means is that we've got several opportunities to prevent this cancer. First, by what we call primary prevention here, preventing the infection by vaccinating young people in early adolescence. By using Pap smears, if we're able to get to everyone every 3 years, we can have quite a good effect, although, as you've seen, that's plateaued out. But the really exciting innovation is by using this HPV testing, we can screen less often and be more effective at preventing the cancer. And there's not many things in medicine that require less intervention but give you better outcomes. So our program, our vaccination program, started in Australia in 2007, just a couple of years before the Malaysian program. And like your program, we've been quite successful in achieving high coverage, although we were very late to change to the the 9-valent vaccine in 2018. And that introduction of the vaccine program, as Zakiah has already alluded to, has an impact on screening, and this is how. So this graph shows you over time how common for various age groups these precancerous abnormalities are. And you can see that prior to vaccination starting, there was just a general upward trend. And then after vaccination started, with the youngest of women, we started to see an early turnaround time in precancerous abnormalities. And then older cohorts successively have turned around. And what this means is that when you look at a Pap smear, you're looking for a needle in a haystack. The needle are these precancerous abnormalities, and there are fewer needles, same haystack, And in fact, cytology screening in that setting, where there are fewer precancers, becomes less efficient and less accurate. So we needed something else. And around this time, this is 2008, there's this publication that shows what happens over time in studies that are comparing screening with a Pap smear, that's cytology there, or screening with an HPV test in red, or screening with both. So each patient gets both tests. And what you're looking at here is following a negative test of either type or both over time, how common these important precancerous abnormalities are. And so over 3 years, you get up here to about 50 per 10,000. And if you can screen every 3 years and you've got good quality labs, then it's very, you do deliver quite low incidence. And we've been quite successful in Australia, although stuck at about 5 or 6 per 100,000. However, compare that with the amount of disease amongst women who screened negative for HPV. And even here at 6 years, it's lower than what it was 3 years after a PAP. And so what that means is after a negative HPV test, you are far less likely to have a precancer for far longer than after a PAP test. And you'll see here the very small negligible advantage that you get from doing both tests. So that's really important. And this is what gives us the capacity to extend out the interval and really have a good impact, even in some LMIC. 2 tests in a lifetime are, as you will see, predicted to have a very important impact on incidence and mortality. These studies were put together somewhat later to look not at precancer outcome, as I've just shown you, but actual cancer outcomes. And the bottom line here is amongst women screened with an HPV test, cancer rates are extremely low, but about half as common. So reductions of 60 to 70% against invasive cancer compared to screening with cytology. And that's an extraordinary finding. And should be pushing us all to change the way we do things, even those of us who like looking at Pap smears. So way back in 2009, the Australian government launched this program called Renewal, where they wanted to ensure that having introduced the vaccine program, we still had a successful screening program, and that Australian women had access to a program based on current evidence and best practice at the time. For all the reasons I've told you, new knowledge about the development of cancer, new technology and the vaccine program, acknowledging that Australia, by international standards, had a relatively intensive screening program. So we did look at a range of ways to do this, and Karen Canfell and her team did a heroic job of assessing the effectiveness and with modelling the cost effectiveness of a huge number of algorithms. And I'm going to leave the punchline there, except to say that in 2014, the Australian government announced we would make this change, which we did at the very end of 2017. I'm going to make a few remarks about the importance of cancer screening registries. We've had those since the early 90s, and about how this supports organised screening. So the function of these registries, these are not cancer registries, but they are to collect information about all screening activity, ideally across the entire health sector, public and private, different providers. And what I mean is demographic and contact details about anyone screened, and information related to all relevant tests and treatments. There's an important function of actively following up screen positive participants and a cascade of activities to contact those who haven't apparently had assessment and treatment and try and get them into assessment and treatment. Because as you can imagine, doing a primary screening test is not going to prevent cancer if we don't get people in for assessment and treatment when they screen positive. The registries can recall for rescreening at the interval, whether that's 10 years or no less than 5, and can provide important information to national governments about how the program is performing. We have this CanScreen software we've developed. It's been supporting the Rose Foundation. And the idea of CanScreen is that it's a population health platform that can support really a variety of population programs through this life cycle of screening monitoring evaluation, and program performance. So just to give you some of the things we've got from our register prior to the switchover, you can see here we were able to look at our participation over time in our old program when we were targeting 2-year participation. You see 3-year and 5-year participation is really pretty high, and that's important. But one of the things that I think has been very important is that through these state and territory registers in the PAP program, we were able to get almost all women to follow up. So the green boxes of people that we couldn't show had been followed up. And this follow-up is achieved by women going to assessment and treatment through their doctors, but the registry providing the safety net to contact them and their doctors if they're apparently not followed up, with a series of reminders driving up those rates. And I think that's what's been pretty important in keeping incidence and mortality down in Victoria, which is where I'm from, where our mortality rate has been very close to 1 per 100,000 for a long period of time. It's that follow-up that's so critical to achieving that. So I'll just close by saying, as a lab director, change is hard. I used to have 50 scientists screening Pap smears. We now have about 12 people doing cytology. There's still a role for cytology, but not primary screening. But we got there in the end. We have more modern tests, and we hope that we can help others get there too. Thank you very much.
Thank you, Prof. Marion Saville, for a very informative presentation. Ladies and gentlemen, we have 2 more speakers coming up. Now, let us hear more from Professor Dr. Woo Yin Ling, who will share with us the transitioning from Pap smear to Hpv testing in Malaysia. Over to you, Professor Dr. Woo.
Thank you, Shida. Can you see my slide and can you hear me?
Yes, loud and clear.
Right. So I'm going to quickly spend some time to convince you why we should be transitioning from Pap smears to HPV testing. So, as we've heard, cervical cancer is the 3rd most common cancer in Malaysia. It presents late, so nearly 50% of women who present with cervical cancer present late, and half of these women will die of this disease. Now, the thing that is so unfortunate is this cancer is preventable, and in fact, we can eliminate it. Now, I'm just going to show you a graphical representation. If you look at the graph on the picture on the far left, that's a normal cervix and a normal uterus. As you progress on with the advanced disease, you will see that it requires much more effort and much more cost to the woman financially and physically to actually deal with this disease. I want to show you the study by Action. It's done in Asia Pacific. If you look at the impact of cancer as a whole on in Malaysia, you will see that half of our population, and I'm sure we know someone or other, if someone in the family is diagnosed with cancer, half of these families will face financial catastrophe within a year, regardless of whether they survive or they live. That's a very important and sobering fact. And these are some of the patients that my colleagues and I have looked after in Malaysia. Both of these are single mothers. Both of them have left young children behind. And you can see in the graph, or in the picture on the right, the patient is actually going through the bill, and that just shows the financial impact cancer has on the woman and on her family. Now, why should we prioritize cervical cancer? As insurers, as doctors, we have so many diseases we need to tackle. But why cervical cancer? Because it is a common cancer that affects young women during their reproductive age. We no longer need to research any more tools. We have vaccines and we have screening methods that work. Malaysia already has an extremely successful vaccination program. We just have to meet the gaps and implement screening and treatment in a patient-centered manner. And we cannot leave this for the Ministry of Health or for one party to do this. We really need to get our act together as a community. So if we are limited by resources, many countries are going through economic crisis. What diseases do we tackle first? This is a study done by World Bank in terms of cancer control priorities. And you can see here, when it comes to breast cancer, we're not even talking about mammogram. We're talking about the ability to treat the cancer. And if it's colorectal cancer and if our resources are limited, we are talking about the surgeons that are available to do emergency surgery. But for cervical cancer, it's a very different story. The cervical cancer prevention is viewed as something that's very cost effective. We should be vaccinating and we should be screening and we should be treating pre-cancer and cancer. And so in 2018, World Health Organization set this target, which Malaysia has adopted, which is to get 90% of our girls vaccinated with HPV vaccine, to get 70% of our women screened by HPV test at least twice in their lifetime, and most importantly, for those who are screened positive, they are guided to treatment, the appropriate treatment. Why are we able to actually eliminate this cancer? Because more than 99% of cervical cancer is caused by HPV. Now, this is very important. HPV, as Mark pointed out earlier, is not a sexually transmitted disease. It is a common infection among men and women where we are able to clear the infection. However, some of us, due to factors that we still don't fully understand, we cannot clear the virus and we don't get into a situation of latency. The virus stays active, persistent, and it's able to cause changes on the cervix. And these are the group of women we need to identify. So it's extremely important that we don't classify a common infection as a sexually transmitted disease. So we're very proud of this. The Ministry of Health has done an amazing job in vaccinating our 13-year-old girls since 2010. So it's now been more than a decade. So we just have to add this little bit more effort, as Prof. Adeeba highlighted earlier on, to screen. I want to show you the picture that Marion showed earlier on. The intention of this is to show you that the development of cervix cancer takes about 10 to 15 years in someone who has a functioning immune system. And so there are many opportunities to detect this process before it becomes cancer. Now, if you were to look at this process through Pap smears, it needs to be done regularly and it's not foolproof. A Pap smear, as we will see, is only 50% sensitive. We now have very good molecular methods to actually detect HPV. And we must promote this screening method to ensure that more women are detected earlier on and not late in the process where they are symptomatic. To do this, one of the things we have to ensure is to ensure that women come forward for the test. And as seen in many developed countries, such as in Australia or even in UK, by changing the method of screening, sometimes we have to deal with stigma as well. And so this is quite important. As a community, we actually bust the myth around HPV infection. Cervical screening in Malaysia has been around since 1969. In all Ministry of Health clinics, this has been in the form of Pap smear, freely available. Unfortunately, only 20% of women would have ever had a Pap smear in the last 5 years. And most women do it postnatally. There's no infrastructure at the moment for recall and call, and it's pretty much ad hoc. Now, many of us go for health screens, but unfortunately, cervical screening has been excluded in the screenings that even we voluntarily go for. Now, what I'm going to show you here is not to pick on anything, but I just want to show you a typical package of a screening package. You can see this is a cancer screening package. And look at that. It offers visual acuity test, color blindness test, various types of blood, but it doesn't offer cervical screening test, which is the most preventable form of cancer screening. So I think we must move towards evidence-based screening that actually can prevent cancer. So differences in Pap smear. Now, for Pap smear, for those who don't know, you need an uncomfortable pelvic examination. It's not very sensitive, but it works if you go for it regularly, i.e. every 3 years. And as Marion has shown you, even in Australia, where they have a very robust and good screening program, it's reached its maximal capacity of reducing the impact of screening on cancer. So we need new screening methods, particularly among those who are vaccinated. So for HPV testing, I want to show you this. It's exactly like a COVID test. You can get the DNA using a swab like that. A doctor can help you do it, or patients can actually do it themselves. This is a swab similar to a COVID swab called a flock swab. And WHO has said that as few as 2 tests in your lifetime is enough to prevent cervical cancer. Infrastructurally, Malaysia has the ability to perform this test. You can see how good we have been with PCR in terms of COVID, and those are the same machine that can be used for HPV testing. It is more cost effective. I want to show you this graph once again because I want to talk about the treatment and the cost when women present late with cervical cancer, which is the situation in Malaysia. So this is normal. This is early, very early stage, and this is the later stages where it invades near the bowel or the bladder, and this is when it bleeds. In this early stage, sometimes or most of the time, women don't bleed at all. How do you treat it? This is for the insurers or those who are dealing with claims. If you have an early cancer, you can talk about excision or removing this area that's affected. So if women present early, the treatment is curative, it's very simple, and you can even do a simple hysterectomy. Now, in sort of the later stages of stage 1 or stage 2, you can either do a radical radiotherapy or radical surgery. Sorry, there's a typo there. Radical surgery or radical radiotherapy, either or, and both are also curative. And in the later stages, where you can only treat with radical radiotherapy, there are lots of complications such as anemia, abnormal connections between the bladder and the bowel, where we call fistula. So the treatment is actually quite complex and the curative rates are low. I'm going to sort of, in the best scenario, with the help of my colleague in the Chuan, who's in the social preventive medicine, looking at the cost of treatment. This is using the fees in 2014 in the government sector. Now, we've done this as best as we can, but it's not accurate, but it's just to give you an idea how much it costs for cancers to be treated in the government setting. Now, if you look at this early stages where there's pre-cancer or there's stage 1 cancer, you're talking about very simple treatment that's about 2,000 plus or 3,000 ringgit. Now, when you look at simple or radical simple hysterectomy, that goes up to about 10,000 ringgit. But if you come to a bulky stage disease where you need radical radiotherapy or radical surgery, the cost escalates up to 44,000 ringgit. Now, in a situation where the choice of surgery was made perhaps inappropriately, a patient needs to have radical surgery followed by radical radiotherapy, and there you see the cost doubling up to 80,000 ringgit. So if you've not treated it correctly, you might need to use two forms of treatment, which unfortunately is very costly, and the side effects are both the side effects of radical surgery and radical radiotherapy. And when you have advanced cancer, of course, the cost goes up. And I would say these costs are very modest. I believe the cost is actually much higher today. So if we look at the pathway of cervical cancer screening and follow-up and in Malaysia, this is what I've heard and what we can talk about perhaps a bit more from the whole screening life cycle, right, and the treatment. Screening is very much on a voluntary and ad hoc basis. Is there any way at all we can encourage prevention so that we don't invest money in a sick care system, but a health care system, a system that actually prevents disease from escalating into something that's non-treatable? Could we perhaps encourage women to do tests such as Hpv testing instead of Pap smears in validated laboratories? When it comes to abnormal screening tests, if we were to do Hpv testing, which I hope by now you are convinced is a more superior screening method, can we declassify that as from being called a sexually transmitted disease so that women can be reimbursed appropriately if they go for prevention? Now, the other thing is I want to persuade our insurers to whether or not we can have all the investigations to be done on an outpatient basis. We know for many women who need to be investigated for treatment, they are often admitted just for scans to be done. And I don't understand this perhaps, but when patients tell me they have to be admitted so that they can put in a claim. Can we perhaps have a discussion about this? And so if we encourage investigations and treatment to be done as an outpatient, we can really make things more cost effective so that the payout will also be less. And when we talk about treatment after what I shared with you earlier on, perhaps on the doctor's side, we need to think about how to treat patients more appropriately and perhaps follow guidelines through educating our next generation of doctors, but really not to put patients through too highly morbid treatment, but rather choose those that are more appropriate and most appropriate. So in terms of where we can play a role, we really should together encourage evidence-based prevention, encourage outpatient management as far as possible so that the hospital can be kept to deal with more acute sort of conditions, and we should reimburse based on evidence-based practice. So, ladies and gentlemen, we're not talking just about a test. We're talking about a life course approach. We're talking about vaccines. We're talking about screening appropriately. And most importantly, we're talking about treatment. So where do we fit in this big jigsaw puzzle? What policies can you set up? How can we encourage the women around us to be screened, to be treated appropriately? I think we all have to play a role here, and we fit in the life course approach in whatever we do, in whether it's our policy or our practice as doctors. So the topic given to me was, I gave myself was transitioning from Pap smears to Hpv test, but really that's not the right topic. What we should be thinking about is how we transition from Pap smears to a comprehensive cervical screening program towards the elimination of cervical cancer in Malaysia. So I think this can be achieved. It has to be sustainable through partnerships that work. You can see all our friends here. For those who didn't see Zakiah, she's here in the photo in her pink dress. And we really do need an all-society approach, not just health workers. And I hope to convince Liam and all its members that you have an extremely important role to play. Thank you very much.
Thank you, Dr. Wu Yin Ling, for an interesting sharing. And in fact, for showing us the demo just now. It looks so simple, so easy. Thank you so much for the demo. Right now, we have come to our fourth speaker for the day. Please welcome Prof. Karen Canfell, who will speak on the ROIs and cost effectiveness of moving from Pap Smear to HPV testing. Over to you, Prof.
Thank you so much. I hope you can see my screen okay. And
yes, I'm able to see your screen, yeah.
Great, thank you. It's a real honor to be here. Thank you. And I'm going to talk a little bit more, picking up on the presentations by Prof. Saville and Prof. Wu on the economic evaluation aspects of assessing moving from Pap smears to HPV testing. So you've heard today already that primary HPV screening has many advantages, and these include the fact that it's a more sensitive test. So this means it has a better negative predictive value, and therefore it can support a longer screening interval than Pap smears. Now that's really key to the economic aspects, because we can actually achieve better protection but screen far less frequently. As you've heard, even twice in a lifetime provides significant protection for women in a population, although some countries go up to 5 years is preferred. It also allows for greater automation and standardization. It allows for sample self-collection without loss of accuracy, which is certainly not the case for the Pap smear. And portable point-of-care HPV testing is also an option for delivery in the right setting. Now, as I said, I want to talk a little bit about the economic evaluation of HPV screening and, of course, some of the modelling that is being done that my team have been involved with in quantifying the effectiveness and cost effectiveness of HPV screening in many countries. So we've used a platform for this economic evaluation exercise. It's called Policy One Cervix. It's been developed by our team with our collaborators in many countries over many years, and it's informed by extensive in-country data and tailored to a particular setting. And so it does provide a full model of HPV. It provides a full model of cervical screening and also HPV vaccination. And it's been used in many high-income countries in government commissioned projects. And it's also the platform that supported WHO in their recent development of new cervical screening guidelines. So I'm just going to talk first briefly about my own country, Australia. You've heard a little about what we've been through in Australia so far, but I really wanted to give you a sense of the economic case for transformation of our screening program. As you heard from Prof. Saville, it was in 2017, so now almost 5 years ago, that we transitioned to HPV testing from the previous Pap smear program, which had been in place over a quarter of a century at that time. And so it was certainly a large-scale transformation of what was a very widespread routine program involving 2 yearly Pap smears. We then changed to 5 yearly HPV testing. Now, this is a complicated slide, but it shows some of the cost effectiveness results that underpin that government economic decision, not just a health decision, to actually transition to HPV screening. We did look at a whole range of possible future options for screening with different tests and with different sequelae in terms of the management of results of those tests. In fact, we looked at 132 different strategies with our platform, with different screening intervals and ages of screening. Many of those were based on Pap smear screening, and many were based on HPV molecular screening. The graphic on the right shows what's technically called the cost effectiveness frontier curves. The most important point to take on board from this evaluation is that we actually found that most of the strategies we were looking at were in fact cost saving. So on the right, this shows you the previous, it says current, that was the older practice for 2-yearly Pap smears. And then we looked at a number of longer interval strategies with HPV screening, finding that they unsurprisingly would save costs because you don't deliver screening as often. Also, on the x-axis here, you can see the effects. We actually saw that HPV screening increases the effectiveness of screening, and that this was true at the top for unvaccinated women. And even when you're considering a situation, as you are in Malaysia, of course, where young women are now being offered vaccination, have vaccination, and are reaching the potential age of cervical screening. Even in that situation, HPV screening is much more cost effective. In fact, we found that it's not only that HPV screening is cost effective, but ultimately it's cost saving, which is an extraordinary result in this type of evaluation. So if you like, this is a win-win situation. We're saving more lives and we're saving costs to government or to the healthcare payer. And this slide just shows some of those results in a slightly different form. So you can see the predictions from the previous Pap smear program on the left and the HPV screening program that we finally moved to, showing that over the longer term, we predict a reduction by almost 1/3 in cervical cancer incidence and mortality in Australia, and that this would save a considerable proportion of cost to the program, actually cutting about 1/5 of the cost of Australia's screening program, saving between $41 and $50 million a year. So you might say, well, that's great, but that's Australia, that's a particular situation. But in fact, we've seen how this has played out more broadly. And before I go on to that, it's also important to say that it's actually this decision to switch to HPV-based screening that has positioned Australia to be the first country in the world to eliminate cervical cancer. Now, in saying that, I emphasise the importance of the high coverage vaccination program, as you have in Malaysia and as we do in Australia. But vaccination is a long-term game changer. It's something that will protect future cohorts of women as they age into the peak age of risk of cervical cancer, which is mid-adult and older women. So there's a delay between when women are vaccinated or when girls are vaccinated and when they experience those life course protective effects that Dr. Wu talked about. So the key thing to understand is that to actually move the dial, as it were, to reduce incidence rates quickly in a country, HPV screening and the switch away from Pap smears is the key way to do this. And so you can see this is our prediction for cervical cancer incidence rates in Australia over time. And in this period between 2017 and 2030, we see a rapid fall due mainly to the switch to HPV screening before the longer term effects of vaccination kick in. And so using this approach, we've predicted that Australia is positioned to eliminate cervical cancer by 2035. So these results play out similarly in other countries. And just to give you the high level overview, government commissioned work in New Zealand and in England found similar results. And by similar results for HPV screening, what I mean is that HPV screening proved to be not only more effective, saves more lives, but also saves costs to the healthcare payer. So these results show that the actual degree of cost saving varies between countries. And it's important to note that all of these countries had different starting points in how they were using Pap smears. They were using them in different age groups of women. They were using them at different intervals, and they were using them in slightly different ways. But the broad consistency is there that no matter the setting, a switch to HPV screening saves costs as well as saving lives. I want to turn briefly to some work that our team has done with Prof Wu and her team, which really shows that effect I was talking about before, of bringing forward the elimination timing. So I showed you a graphic for Australia before. This is a new published paper from Adam Keane and our team that was just published in the International Journal of Cancer. And this shows the elimination timing in Malaysia. So this shows the current rate of cervical cancer incidence here along the top. And the blue region shows the prediction with the effect of vaccination alone. And you can see that we will get this important and incredible long-term effect with vaccination, but that the elimination timing is after 2066. However, if HPV screening can be rolled into a comprehensive program such as Prof Wu was talking about, we can bring this forward significantly and substantially by 1 to 2 decades. You can see that's the difference with introducing HPV screening. And this similar picture plays out even in the poorest countries in the world. So just briefly, I want to talk to the work that we've done to support WHO's planning for cervical cancer elimination. This is cervical cancer mortality, and this purple, this is unchanged rates if we don't scale up vaccination, cervical screening, and cervical cancer treatment access. But you can see in the purple line here, with vaccination plus twice lifetime HPV screening and cervical cancer treatment, there are extraordinary and rapidly unrolling effects. And those early effects are mostly due to screening, HPV screening and cancer treatment access before, again, the long-term effects of vaccination kick in. Similarly, in 2021, the World Health Organization revised their cervical screening guidelines and updated them, reviewing the current evidence. And I just want to show you some of the effectiveness and cost effectiveness results. So this is in the 78 poorest countries in the world, 78 LMIC. And this graphic just shows the different types of screening strategies, Pap Smear strategies and HPV strategies. The take-home message here is, again, even in low and middle income countries, HPV screening is the most effective option. And in this summary slide, the take-home message here is that the green is the most cost-effective options, and those green labels are all attached to HPV screening strategies, not to Pap Smear strategies. So even in low and middle income countries, we see the same result. The most cost-effective approach is to use HPV screening. And this has supported recent WHO screening recommendations that actually unequivocally recommend that HPV molecular DNA detection is used for screening globally. This is cost effective, even, as I said, in low and middle income countries. So we found overall, when looking at the 90-70-90 targets for vaccination, screening with HPV twice in a lifetime, and access to cervical cancer treatment services, for 95% even of the poorest countries, scale up to these targets will not only result in elimination, but it will be cost effective. And if these targets were implemented, there would be, even in low and middle income countries, a $3.20 return per dollar invested to the economy. And if societal impact is taken into account, a $26 return on every dollar invested. So that includes twice lifetime HPV screening. So in conclusion, I think from an economic and a health point of view, primary HPV screening is just a win-win compared to Pap smears. At a population level, there's more effective protection against cervical cancer. That's a given. And we have a large range of trials and cohort studies now showing that. It can support longer interval screening, which is better for women and providers, and it can support the self-collection option. And it's not only in a country that's already doing Pap smears, or a setting already doing Pap smears, it's not only cost effective, but it's actually cost saving. So just pause and think about that for a moment. It's not only that we should be prepared to pay additional costs for an effective and cost effective technology. It's one of those very rare situations in health economics where, compared to Pap smears, it's actually going to save costs. It's going to return dollars to the system. And that's again because of the longer interval and the very, very efficient screening program that's possible. There's consistency in these economic evaluations across countries, even given major differences in country economic profiles, in the background uptake and recommendations for Pap smear screening, and even in the test costs for Pap smears and for HPV tests, which vary, of course, from setting to setting in these analyses that I've shown you. But fundamentally, this better performance is due to HPV being such a direct test for the causal agent for cervical cancer. So it's very, very efficient at identifying women at risk, and that's what makes it so cost effective. So introducing HPV screening is the key step to promote early cervical cancer elimination in any setting, and I believe it's one of the best spies in cancer control. Thanks very much.
Thank you, Professor Karen Canfell, for the presentation. We have now come to the question and answer session. I would like to invite Mr. Mark Odell once again to moderate this session. Mr. Mark and fellow speakers, please switch on your mic and camera. So audience, if let's say you have any question, you can click on the button on top of the screen. You may raise up your hand and I will read out your question. But we do have one question here. Let me see. Why is HPV screening not commonly offered in private hospitals and not part of normal overall health screening in Malaysia? Instead, they still propose Pap smear, Dr. Zakiyah. Can MOH push for HPV screening in both private and government hospitals instead of Pap smear, since the former is more accurate and cheaper? Alternatively, have the HPV screening costs as tax deductible twice in a lifetime? So I believe, Dr. Zakiah, the question is for you.
So thank you for the question. So basically, as I have mentioned just now, in 2019, Ministry of Health has endorsed HPV screening as a way forward for the cervical cancer prevention and control program in Malaysia. So ultimately, this policy is actually a government policy. So in terms of the implementation, we have actually to play our role. Different stakeholders must play their own role. In fact, I can see that most of the states in our government health facility has already adopted this policy. So I think that in terms of enhancing the policy to the private sector is something that the private have to initiate that. So in terms of getting the guidelines to be shared with you in the private sector, it's actually something that we, the government, and also the Ministry of Health is welcoming and also very happy to actually to collaborate and to participate. So to conclude that, well, this policy is not mainly for the Ministry of Health policy, it's a national policy, the Malaysian policy. So in terms of accepting and adopting it, I think the different stakeholders and different agencies must actually play their own role. Thank you.
Maybe this is Mark. I just want to add, because I can relate, although I'm not a woman, but my wife recently had an exam. She never even heard of this HPV sort of PCR test. It was not an option given to her, right? I think there needs to be more done. Perhaps this is one thing that we can take offline with the Rose Foundation. What more can we do in the private sector, right, to promote the the use of these screening tools?
Yeah, I've got something. I've just had a message come on board on the other screen. It's just that in the private sector, many people perceive HPV tests as being expensive. Now, as a once-off test, it may be expensive, but if we follow the actual guidelines of, say, every 5 years or 10 years or twice in a lifetime, Karen has shown beautifully It is cost saving, and they've done it in every single setting. Even from the poorest country, if you do HPV testing, it's actually cost saving. So I think this is something as doctors we need to teach our colleagues a bit more, and we do have a role to do that. It is a relatively new test in many places.
I mean, it's also striking that it's not just about the cost; it's actually much more accurate, right? I mean, many people would be happy to pay a higher cost if if the effectiveness of the test was greater, right? So yeah, I think a lot of work needs to be done there. Thank you for the question.
Marion, I saw a hand there. You want to ask,
Yep.
or you want to add something?
Yeah, I just want to say that for us, one of the barriers was getting the private labs to change their attitude. People like to keep looking at Pap smears if that's what they've been doing. But I think the pandemic gives us a bit of a opportunity now, because most labs around the world, and mine is one of them, has scaled up to do a lot of COVID tests, and we have a lot of capacity. And as that tails off, they'll be looking for revenue from those instruments. And of course, screening is high volume for a laboratory, much more so than diagnostic testing. So maybe talking to them in terms that make business sense for the laboratory is also another opportunity.
Yeah, good point. Good point.
We have one more question. Is HPV vaccination encouraged for women of all age?
I'll take that question. So as a life course approach, and certainly looking at the public health picture, HPV vaccination is most effective given to adolescents. It used to be 3 doses. It's come down to 2 doses. And there is some suggestion and evidence that among the adolescents now, particularly during these COVID times, 1 dose may be sufficient if it's an adolescent, but that's not sufficient yet as a recommendation. Certainly there was data coming through from Australia to support 1 dose. But for women, for adult women, the most effective is actually HPV screening. The vaccines don't treat, they prevent, and so the best time to vaccinate young girls are before they become sexually experienced.
Maybe Professor Wu, let's bring up the topic about, do boys need to get vaccinated? Because I mean, this virus is prevalent in both men and women, right? And so we always think about women getting vaccinated or young girls getting vaccinated. What about young boys?
Okay, so the modeling has been done, and I think in Australia they took the decision of equity and to cover the other boys. But in Malaysia, if we are getting extremely good coverage at 90% as a public health measure, that is sufficient for cervical cancer prevention. On an individual level, if boys choose to be vaccinated, they will have the additional benefits of having that done. But the other thing we have to think about is resilience in a program. So your vaccination program will work if a large population of the intended population is vaccinated. What COVID has shown in the last 3 years is that many countries have not vaccinated their girls. Now, if you had a program that vaccinated girls and boys, and if COVID happened, in the situation of COVID, you still have some resilience in the program. But this is in terms of cost, I'm sure Marion and Karen, you may have something to add to that.
Yes, yeah, thanks, Prof. Wu. Just to endorse your comments, I think that vaccination in boys is effective, but whether it's cost effective is quite dependent on the country setting in terms of how much coverage coverage has been achieved in females. And also, of course, vaccine price is a key determinant. So really that supported the recommendation that the first target population is young females, and if a high proportion, as in Malaysia, can be vaccinated, that actually, of course, provides extensive lifetime protection to males in the population as well. And so that's the first target population. Then if vaccine becomes affordable, and particularly when we move to one-dose vaccination, I suspect we will see more countries looking at the cost effectiveness of male vaccination again as a way to increase overall population coverage. But again, I think Malaysia has, has really followed the strategy that's the most effective strategy and will protect against the highest burden of HPV-related cancers.
Okay, thank you.
We have another question for Prof. Marion on managing HPV result. What's next for HPV positive? For HPV negative group, how many of them have high-grade CIN? Do we need to worry about high-grade CIN with HPV negative?
So I'll take the second part of the question first. And the overwhelming evidence is that high-grade CIN is very unlikely at the time of and for a long period of time after a negative HPV test. You are much safer 5 years after a negative HPV test in terms of high-grade CIN than 3 years after a Pap smear, for sure. In terms of what to do after a positive test, there are a range of options, and they are quite complex. Here in Australia, we do make that decision based on whether they are the most oncogenic types of HPV. They're the vaccine preventable types. If we find those types, then women are referred directly to colposcopy for follow-up. If we find the other types that can be associated with high-grade disease, but have a lower association, the current policy in Australia is a 1-year repeat HPV test, and then a further year after that. So we do monitor them with annual tests, but if at 2 years HPV is persistently positive, at that stage they go to colposcopy. And I think that's an area, that triage of how we manage people who are positive is going to be the focus of a lot more research and evidence. And I know that there's a big piece of work going on in triage. And so I think we have some good strategies now, and I think the strategies will get better into the future for how we manage them. But the really critical thing, particularly if we're sending people away for a year, is that we've got a way of following them up and bringing them back in if they don't initiate any follow-up at a year. And that's where the importance of call and recall or registers comes in.
Thank you, Professor Marion. We have another question. I think Jane Lee, she put it this way: with previous findings of a positive HPV test and or abnormal Pap test, example CIN, SIL, and the individual is on close interval follow-up, what should the choice of tests and testing or follow-up duration look like? Example, HPV only, Pap only, or Pap and HPV. Who's going to take that? Dr. Wu?
I can start if you like.
All right.
The answer is it depends. And if you've had a biopsy confirmed pre-cancer, mostly you need co-tests for a couple of years when they're negative. So people who've been treated for pre-cancer are at higher risk of recurrence or of developing a cancer. But we do know that if they've had 2 negative co-tests, they go back to baseline community risk and they can be screened at the baseline community level. If you've had a low-grade lesion, you probably need another HPV test in a year to see where it's going. But this is what will be in your guidelines that Zakiah talked about, those algorithms that map through the various combination of results. It's very important that a country has those guidelines in place and has considered all the evidence as you have in Malaysia.
Can we have Prof. Adeeba, you want to add? You raise up your hand. Oh, is that an old hand?
Yes, I do, but I actually have a question for both Karen
Okay.
and
All right.
So perhaps for attendees, we're really lucky to have both Marion and Karen, and I just wanted to highlight that Australia is actually, of course I'm a big fan of Australia, right? It's well on its way to eliminating HIV, hepatitis C, as well as HPV now. So 3 viruses well on the way to eliminating in Australia. There's a lot that we can learn from you guys. So what do you think are the essential elements that Malaysia can emulate? Because it's not just about money, is it? Of course, that helps a lot. But you know, I certainly know a little bit from the HIV, Hep C end, but putting together, what do you think are the key elements that we can learn from Australia to eliminate those 3 viruses?
Well, that's a great question. Thank you so much, Prof. Adeeba. I'll start. I will confine my remarks to HPV if that's okay, because I'm no expert in the other 2. But I think it's all about, as you say, it's not just about money, it's about health, and it's about the fact that this is a incredible first in world opportunity to actually eliminate a major cancer. I mean, that's something that I personally reflect along a lot. We have evidence-based interventions, and their HPV vaccination and HPV-based screening, which are proven to work. And so what can we learn? For me, I think the challenge for countries is to really implement HPV screening, but in a systems manner, thinking about the data, thinking about the monitoring, thinking about the flow, thinking about the referral, thinking about making sure that those women that are now HPV negative at incredibly low risk are not actually coming back for testing in a year, because that will provide no benefit at very little. Very little benefit at extra cost. So it's about that systems level thinking, which Prof. Wu I know speaks to very well, and I think that is what Australia has managed to do with all of the challenges that we've had in terms of organising our approach to screening.
And I would just add the critical importance of data and informing those systems approaches, and being able to figure out, as Karen said, not just counting screens, but counting screened individuals. So if you have some people getting more frequent screening, that's not cost effective, and then you're wasting a resource that could be used for an unscreened or unscreened woman. And I think the other dimension that we're tackling now in Australia is that of equity. So we know there are disadvantaged groups in our community that don't have the same access to screening, or indeed in some cases vaccination, but more so screening and the appropriate treatment. And we haven't got our action plan for elimination yet. We're developing it, but a major lens that we're putting across the 3 pillars is equity. Who are our populations that we're reaching? Because I don't think anyone, Karen or I or anyone in Australia would be satisfied if we get to 4 per 100,000, but Aboriginal women are still 3 times more likely to die of this disease. So, and it's not just Aboriginal and Torres Strait Islander women. We know that if you're poor, you're more likely to get and die of this disease if you're from many marginalised communities. So that's a lens that we need in our programs too as we get organised.
Right, thank you, Prof. Marion. I think we have 2 more questions in the chat box. It's about the challenges faced in promoting and implementing HPV testing, i.e. limited availability in private hospitals, clinics, cost, limited expertise in handling specimen, and the interpreting results. In fact, there is a question for Professor Ling. Can you indicate what's the difference between HPV test versus Pap Smear in the private sector?
Thank you very much. I always believe doctors are quite slow to adopt change. As humans, we especially doctors, I find that it's very difficult for us to bring in new evidence and change our practice. It threatens us. It threatens our authority. And so I think that's one of the major barriers. Cervical screening has really undergone a tremendous change, a paradigm shift. So you can't be waiting for your 30 patients to see you all their lifetimes when they've had babies in their 20s. You've been offering them Pap smears all their lives until their 50s, and now you're telling them they need HPV testing. That's a big change. But it's a change that needs to happen. In the laboratories, we've had, like Marion says, loads of cytopathologists who've spent their whole lives training, their income, their careers, have been looking at slides of Pap smears. And now we're telling them, look, this machine can run 1,000 tests in 4 hours. I think we can take it personally at times. And so change is here. We need to adopt it. It's not expensive. If we go into our private hospitals, the machine that are running the HIV, hepatitis C test, it's the same machine that will run the HPV test. We need to ask, as doctors, we need to change. The cost is not as expensive as once off, yes, but there might be other peripheral cost, overhead cost. Of course, when you go to a hospital setting, there are doctor's charges, there are hospital charges. So it's not just one test. I think when you take into account all that, it seems a bit daunting. That's why these conversations need to happen so that we can start changing our practices. I hope that answers that.
Thank you, Dr. Wu Yin Ling. Any other question from audience? Anything to add, our speakers?
I have another question.
All right.
For this, that maybe on some of the audience's mind. So, Professor Yingling, we had talked previously about the stigma of, or the misconception of having an HPV PCR and STD, right? And I think even I had heard that somebody may not even get a claim paid for a PCR, test for HPV because it may fall in this category of sexual transmitted disease. And so I'm just wondering, if there's anything you can share with the audience that might change perceptions, right, as to how they should look at that issue.
Thank you, Mark. Actually, this is how it came about. Working in a university hospital, I didn't realize that this was such an issue for my colleagues who were practicing in the private practice. So when they performed an HPV test, which some of them knows it's the better test, and when they had a positive test, the patients were not reimbursed, and that's quite unfortunate. So what we now know is that you and I, all of us coexist with viruses quite happily. It's just whether we keep it under control or not. And HPV is such a virus. Like herpes, when we get stressed, we get cold sores. Like chickenpox, when the immune system gets stressed, we get shingles. Human papillomavirus is common. 80 to 90% of us will have it. We carry it. It's just whether or not we are able to control that, whether we can keep it latent. And so when we see patients who are post-transplant or are in steroids or going through extreme emotional and physical stress, you do see that they have an activation and HPV test does become positive. Now, if we understand that concept, then we will choose, we will be informed and we will not stigmatize. I would, Prof. Adeeba, have you got anything to share about stigma? Really is so unnecessary when it comes to disease management. And I really, these are the conversations we should be having to really protect and help our patients a bit better.
No, I've nothing to add, but let me just say that our experience in recent times of going to the ground right, and taking it right to the community, once they experienced doing the HPV test, they were just, it was transformative for them because, you know, they were really fearful of coming forward because of, you know, the perception around Pap smears and, you know, having to expose themselves to a stranger and the discomfort, etc. So I think it's also up to us to, you know, create the awareness. I truly think the awareness is just not there yet. You know, like what Ling said, us doctors take a long time to do anything. I mean, like I said, in the previous engagement that we had, only now we've been forced to scale up digital technology because of COVID, whereas the bankers and the airline industries have done, you know, self-check-in and self this and self that using computers for ages, and we're still talking about expanding telemedicine. So I think the familiarity that the public have had with COVID testing is also a great opportunity to you know, kind of highlight that there is such a test for cervical cancer or to prevent cervical cancer.
So with that, I think we can wrap up our session for today. Thank you so much for our speakers for sharing your presentation, their idea, insights, and perspective from Australia to us. We have now come to the end of our event. On behalf of Liam, we would like to thank everyone for your kind attention and participation in today's webinar. Indeed, it was a fruitful session and we have learned so much from our speakers about cervical cancer screening, cervical cancer prevention that we can share and pass this information to our family, friends, and colleagues. Till then, I would like to thank everyone once again. Stay safe, take care, and stay healthy wherever you are. Thank you so much.
Thank you, everybody.
Thank you, Mark and Liam, for giving us this opportunity, and to Marion and Carol.
Thank you.
Thank you.
Thank you, everyone.
Thanks,
Bye.
everyone. Bye.